1, 2, 3, 4, 5, 4, 3, 2, 1. One, 2, 3, 4, 5, 4, 3, 2, 1. Well, good morning to those of you who are just joining us. We're going to give another minute or so before we formally begin. Glad to have you. If you can see my screen, which should be the first page of our presentation for today, why don't you go ahead and send me a thumbs up, some kind of notification, and that would be terrific. All right. Thank you very much for that. Got a couple more people to admit in as we go along. And I just got the official word from Zoom after all of you saying people can see my application. That's good news. All right. Now, there may be a few more people joining us as we go along today, but I'll get us formally started and thank those of you who are with us live. Thank those of you who are watching this recording at your convenience. We are glad to have you joining us today for the first of our four-part section of Aging with Grace for the spring of 2023. My name is Seth Stander, and I am the Community Aging Specialist for HHCI CARES, which is a part of the Hope and Healing Center and Institute. And CARES is an acronym for Caregiving, Aging, Resilience, Ethics, and Spirituality. CARES is directed by Dr. Peggy Dettermeyer, and I have the pleasure of teaching all four of the spring 2023 Aging with Grace sessions. Today, I'm going to be focusing on healthcare rights and responsibilities. And in subsequent weeks, I'll be addressing legal considerations, understanding living options, and paying for aging. Now, each session, as some of you are discovering watching this on a recording, are available to you at your convenience. The slides that I share each session are going to be available to you as well. Please come on in, join us. And ultimately, we will send those along your way via Eventbrite after we have completed each session, and certainly by the end of the series. So ultimately, we want to present this to each of you in the hopes of continuing to uphold HHCI CARES' mission to serve our growing aging population and the growing population of caregivers who attend to them. So beyond programs such as these, Peggy and I offer consulting with special emphases on the hopes and challenges of aging. We focus on bioethics, the hopes and challenges of caregiving, and navigating the journey of grief. The Hope and Healing Center and Institute, which is a nonprofit located here on the campus of St. Martin's Episcopal Church, is dedicated to meeting the psychosocial and emotional needs of the entire community. Thanks to some generous underwriting, we are grateful to offer our programming to you gratis. So let's get ourselves started and let's make sure that I am advancing properly. There we go. Technology for the win. Let's go ahead and admit a couple other folks coming in. So let's begin with what the traditional duties of medicine have been. These concepts that you see on your screen: preventing disease, restoring functioning, prolonging life, relieving suffering, and attending the dying. They've been around, of course, for generations, and they have been well articulated in everything from ancient scripture to contemporary text. So that's the framework under which we are operating as we consider what the categories of rights and responsibilities are, not just by those who provide care, but by those who receive care. So as healthcare has become more complex, particularly in these contemporary times, providers are now required to share detailed lists of patients' rights and responsibilities to consumers, and they will include categories we're going to cover throughout today's presentation. You can see here financial rights and responsibilities, treatment plan, information about your provider, information that you provide to your provider, policies and procedures at the healthcare institution, and advanced directives, which we'll spend quite a bit of time on towards the latter half of today's presentation. Now, each healthcare provider is required, as I said, to give you a detailed list of these rights and responsibilities. I've observed, though, without any judgment, that maybe 10, 15% of people read these lists fully. It's similar, if you will, though maybe not in scope, but in concept, to going ahead and just clicking yes on the end user license agreement, the EULA, when you're going ahead and downloading an app on your phone. But they are there for a reason, primarily for your protection, whether or not you've read them fully before signing documents and receiving care. So, as I said, we're going to spend a little bit of time getting acquainted with each of these this morning. Now, financial rights and responsibilities, to a certain extent, it's the most straightforward or the simplest category, but it's also the most expensive. With health insurance, it's a matter of what rate your company has agreed to pay your provider, and whatever is left over, if you will, is yours to cover. Now, without health insurance, or if you are underinsured, you're going to end up with a list of prices that the provider charges for various services, with responsibility for covering whatever you use. Now, I mentioned before, health insurance, no insurance, underinsured, maybe you're out of network, I'll add to that pile as well. Regardless of what the situation is, please remember that you absolutely have the right to negotiate. Be upfront about your ability to self-pay, whether it is the part of the fee that is your responsibility after your insurance kicks in, or if you are covering the entire cost out of pocket. We want you to be upfront about your ability to self-pay, to scrutinize itemized charges, and ask the question, why did I get charged $37 in the hospital for a Band-Aid? Those can be walked back if we go ahead and we take the time to scrutinize what the common cost is for something outside of an acute care setting. Just one example of, I'm sure, many that may already be coming to mind as you consider your various healthcare experiences. I also want you to remember that you can offer an alternate amount. Negotiation exists in this industry in order for providers to receive partial payment versus no payment at all. And if you find yourself in a situation where it looks absolutely hopeless, your ability to pay, ultimately the healthcare provider suffers just as you suffer as well. So please negotiate, negotiate, negotiate. There is a right that you have to follow the treatment plan that is put forward to you, or to not follow the treatment plan which is put forward to you. Everyone has the responsibility to understand what is being planned when it comes to taking care of you, what the benefits and potential complications of those treatments may be. You have the right to ask questions and to accept or decline, as I said, some or all of what the provider is proposing. You have the right to follow up care with a provider outside of an acute care setting, what we call continuity of care. Equal access to treatments. We all know that that is a work in progress, but it is a right that every one of us should continue to speak up for our own sakes, as well as the sakes of our neighbors. And remember, without informed consent, that's the last of the items here on this screen, whatever a provider may do to you could be considered a crime. More likely the crime of battery, not as severe, of course, as assault, but I want you to remember that you have a right to accept or refuse someone laying their hands on you in a therapeutic setting. Now, there are going to be examples of if you are coming in through an emergency room and you are unable to give informed consent because you are in an extreme health risk. People are going to put their hands on you. The question is, when you have the ability to participate in your treatment and discharge plans, to receive what you are then able to make are reasonable requests for treatment, to make decisions about how you continue your care plan moving forward, that's when ultimately your informed consent matters the most of all. So I use the very ubiquitous and not so helpful term information when it came to the categories of rights and responsibilities that you have in healthcare settings. So we're going to go ahead and decode that a little bit now. You have the right to know the identity of your caregivers, their names, their professional credentials. If someone's signing off on a document for you, I think it's important for you to know whether or not that is a physician or whether or not that's a representative from a physician's office, a nurse practitioner, a nurse, a physician's assistant. If it is not one of those parts of a medical team, you absolutely want to go ahead and put the brakes on and say, hang on, who's actually read over my plan of care, let alone sign their name for authorization of it? Again, your right to participate in that it remains absolute, but absolutely as well, you should know who is informed about and making professional decisions, presenting them to you directly or indirectly about said care. That has to be communicated, and by the way, in a way that you can easily read and understand. So if you can't, then you absolutely can ask people to go back and to restate until you are completely comfortable understanding your treatment options, let alone who is involved in your care. If you need translation services, they should come at no cost to you, spoken, sign language, whatever your need may be, that is absolutely a responsibility of healthcare providers as well. Now, can I tell you that this is going to happen on a day-to-day basis and in a timely and convenient fashion? More likely in acute care settings than in post-acute or subacute settings or long-term settings. But the responsibility is still there. You may need to be patient in order to go ahead and to receive the type of interpreter services that you need, where the interpreter is fluent in medical language, which we're going to talk a little bit more about later on. Having a family member translate who isn't as skilled in translating medical language is only useful up to a certain point. Speaking of family, and in this case, a family member's PCP or primary care physician, first and foremost, I hope you have one. And if you don't, please go ahead and take advantage if you have, whether it is a private healthcare plan, whether it is a traditional form of Medicare, Medicaid, whether there is a Medicare Advantage plan. I want you to go out there and make sure that you are taking full advantage of what you are afforded by those plans, which usually includes various annual physicals and screenings. The other reason why you want a primary care physician is not only for that continuity of care that I talked about post-discharge from, say, a hospital or an urgent care, but also because there should be no charge to the primary care physician you engage for accessing your medical records, where you very well may incur a charge if you try to go ahead and to get those directly from the hospital or acute care facility. Something to keep in mind. Also, you're going to want another opinion when it comes to understanding, and this is under the section of receiving information about treatment options, understanding whether or not the prescriptions, for example, that you might be prescribed in the hospital are consistent with and also not financially prohibitive when it comes to the decisions that you have made with a primary care physician or will make with a primary care physician upon discharge. Remember that some prescriptions, yes, there are some rare occasions where the brand name prescription is the most effective. Having said that, there are generics that usually are as effective in most cases. There may also be less expensive options, and there may be other types of plans out there, consumer plans, to go ahead and to help bring that cost down, regardless of whether it's brand or generic, as far as your prescription regimen goes. One other thing to keep in mind, and if you are already set up in a medical practice and you find yourself in need of acute care, remember that you likely have some type of online patient portal. Now, you may not be able to get absolutely detailed records, but if you have your primary care physician go ahead and request hospital records, as an example, you may be able to go ahead and to read summaries, if not the actual records themselves, through your online portal. Something to keep in mind, just like you read after visit reports and all of the accompanying information that comes with what other types of regimens, prescriptions may be prescribed to you as you seek recovery. So understanding policies and procedures, rights and responsibilities. I'm going to go ahead and I'm going to focus first on your responsibility. And this is something which I know can be incredibly difficult when you are having one of the worst days of your life. Try to follow the rules. Try to be considerate. Recognize that the healthcare system is essentially operating with its own wounds. Whether they are outside or self-inflicted. We have staffing issues that continue to plague every level of healthcare. We have questions about experienced doctors in your particular area of medical concern being directly involved as part of the interdisciplinary team versus, say, a general hospitalist or an emergency room physician who is doing their very best to just simply stabilize you and then move you to the next step of, God willing, recovery. But let's talk a little bit about what the policies of the institution are. Let's talk about privacy, for example, and confidentiality. Ultimately, I want you to remember that there are a lot of people out there beyond whoever's providing you medical support in the hospital who could be providing you with more holistic support outside the hospital. But because of the Health Insurance Portability and Accountability Act of 1996, which we all know as HIPAA, ultimately, they can't reach out, hospital staff, and go to your clergy or to other individuals, part of your community support, who can offer you spiritual care, emotional care, psychosocial care without your informed consent. Sometimes it's best to go ahead and to make those requests directly or through loved ones or others that you trust. If there's a hesitation, an abundance of caution, if you will, being engaged by acute care staff to protect your privacy. They're actually doing their job right, if that's the case. Also, being free from abuse, being free from restraints. Now, being free from abuse isn't always. Being free from restraints has to do with any situation other than that which is specifically prescribed and monitored as an absolute in order to keep you safe. If you are in a state of mind where ultimately you could be a harm to yourself or be a harm to others, unless a restraint plan has been put in place, it is supposed to be time bound. There is supposed to be a break from restraints. It is also supposed to be accompanied by careful observation and timely observation. Why am I repeating the words careful and timely? Because ultimately, the last thing we want to hear about is somebody who has a prescription for restraints who hasn't been attended to make sure that you are not being further harmed as a result of said prescription and regimen, and that they are taken off as scheduled / at the earliest opportunity. Otherwise, it is abuse, let alone neglect. Preserving your self-image, making sure that we understand person-centered care is what is in play here. That is going to be a challenge when hospital staff are outnumbered by their patient population. Doing whatever you can in terms of the following rules / be considerate category to introduce yourself to the shift staff, to make sure they know a little something about you. This is not about favoritism. This is about going ahead and reorienting people who are triaging to person-centered care, so that if, as you see here, engage in ethical issues, there are questions regarding your trajectory of care. They are looking at the entire person, whether this is done informally all the way up to asking for a full ethics consult. And this type of relationship building is critical regardless of whether you are there for something serious, but from which you will ultimately completely heal, or whether you are there for something for which your life may truly be at risk of ending. And that brings us to the issue of advance directives. Ultimately, you have the right to have them, and you absolutely have the responsibility to provide said advance directives to the healthcare providers who are engaged in your care so that they can understand how aggressive their care can or should be, depending on your circumstances and what those directives indicate you want with regards to life-saving measures. We live in an age in which we imagine, perhaps, that this has always been the case, that advance directives have been around for us to fill out and to share with healthcare providers. Clearly, it hasn't. 1976. For those of you who were adults in 1976, you may have been paying attention to the case of Karen Ann Quinlan. Karen's parents, they ended up taking the hospital that was caring for her, and I say caring as opposed to treating, because Karen never exited the persistent vegetative state that she entered before she arrived at the hospital. They took the hospital to court. And they took the hospital to court because they wanted the ventilator that was being used to keep her alive removed. So the court did rule in the parents' favor, and ultimately a slow weaning followed. Now, Karen survived that weaning, and she ended up in a persistent vegetative state for 9 more years, most of that in a nursing home, until finally she died. Why was this the case? Because no one thought to ask the question about artificial nutrition and hydration being discontinued, and the court order therefore didn't address those medical interventions. Karen's parents knew that she wouldn't want to live the way she was living, but there wasn't much to be done. So from that case and moving forward in time, eventually we began to see what in 1991 culminated in federal laws providing for the right to have and explaining the responsibility to share advance directives put in place. So patients now have their preferences with regards to aggressive care versus comfort care. If you have them put into an advance directive, they're very likely to be followed unless there are extenuating circumstances, again, for which, thinking back to the previous slide, you can go ahead and work informally or formally to deal with whatever ethical issues may be coming into play or perceived to be coming into play. So why should one have an advance directive? And hopefully I'm preaching to the choir as far as participants in the room and on the screen and via recording. But if you have said, I don't know if I need one, or I haven't gotten around to it yet, good news. It doesn't take long to complete. It doesn't take long to amend as you continue through life. All 50 states, as I said, have some type of law regarding advance directives, thanks to 1991 federal legislation. And generally, states are going to recognize and honor the content of advance directive forms which originate from other states. There are exceptions if that state prohibits actions that are listed in those forms, such as medical assistance in dying, physician-assisted suicide, which most states do not yet permit. Another conversation for another day. I've got plenty to say on the subject of maintaining our autonomy and dignity when it comes to terminal conditions. Suffice to say, there are some states that will honor it right now with specific understandings about your ability to give informed consent, as well as to confirm your terminal condition, and others are not there. What we want in an advance directive, though, regardless of what's put in, is a sense of who you are, what you like to do, what control you want to have, what goals you want to have, not just in good times, but also in challenges, and things for which we ultimately hope. And if you don't think that those are articulated in what look like on the surface dry, boilerplate advance directive forms, just think about the discussions that you need to have when it comes to the potential goals of care. Remember, every single one of us was born with an expiration date. And none of us want to die before living as full a life as possible. But I would also say that none of us wants to live in perpetual misery. There's a certain amount of chronic pain and suffering that we will accept in our definitions, whatever they may be, of quality of life. But ultimately, perpetual misery is not on the table. So let's talk about what the potential goals of care are. These are worth saying out loud. If possible, to cure our disease, to avoid premature death, to maintain or improve our function, to prolong life, whether cure is possible or not, to relieve suffering, whether cure is possible or not, to maintain quality of life, to stay in control of our decision-making, whether we can articulate it verbally, non-verbally, or whether it has been written in, say, an advanced directive, perhaps with accompanying notes that will help us understand what quality of life means to you what relieving suffering means to you, what aggressive care means to you when you are in extremis. Now, let's make sure that, again, we all know this, but it's important to say aloud. There are sometimes contradictory goals of care. Multiple goals of care exist in a variety of situations. Let's use as one example of one that takes priority, even though it may contradict a quality of life issue: chemotherapy, radiation, for a form of cancer for which, after said regimens, you may either achieve full remission and outright cure, or you may go ahead and reduce pain and suffering as a result of being able to shrink the cancer if it cannot be removed altogether. So ultimately, we do have to keep multiple goals of care in mind. Hopefully, they're not involving solely serious situations such as these, but I do want to make sure that we understand that we may be holding up in both of our proverbial hands equal truths, and we simply need to understand that if they may contradict but need to be applied, how will they be prioritized one over the other when it comes to the ultimate goals of preserving autonomy and dignity, relieving suffering, and if possible, restoring full function? So let's talk about the environment of care that exists when it comes to achieving any or all of these goals. We have the medical ability today to preserve and prolong life. We have made some amazing technical progress, with, I'm sure, more to come as the decades of this century continue. We have medical specialties that we didn't have a century ago. We have skills in surgery and in the use of anesthesia that we didn't understand as well a century ago. Intensive care units are miraculous places, as well as incredibly intense places emotionally, not just physically. We have reached a stage where organ failure may not automatically equal death. We have dialysis, as one may possibly wait for a kidney transplant. We have artificial nutrition and hydration. We have heart and lung assists. Ultimately, there may be some scarcity in play, but the technology is there, and with less costs and greater availability, a lot of these things are rolled out to the public in ways that generations before just didn't see. All of this brings up new ethical quandaries, because the environment of care falls into the category of coulda versus shoulda. We can ultimately keep a body going in the ICU with the use of various life-saving technologies, as well as artificial nutrition and hydration. Is that the quality of life the patient would have wanted? Is there a reasonable possibility of recovery, therefore justifying the continued use of such aggressive care? Those are the kind of questions that are no doubt going to go ahead and provoke strong emotional reaction, as well as provoke memory. And fortunately, for those with advanced care directives, with documentation that explains a person's desires in certain circumstances, we can go ahead and take the lead of the patient themselves. And if we can't, then we do the best we can based on the stories we share with one another about what they would have wanted in such a situation as extreme as they're facing. Now, knowing what a patient wants is one part of the lexicon. Another part is understanding the lexicon of what acute care institutions use, but also Some of the language that's in here is going to be used in advanced directives. It's going to be used in subacute or post-acute facilities. It's going to be used in home health care and hospice services. Hospice under the umbrella of palliative care or comfort care, if you will. And they include such things as I mentioned before, an intensive care unit. Why is an intensive care unit different than, say, an IMU, an intermediate care unit, or a general care unit? Well, because ultimately the fragility of the patient is much more extreme, which means that already walking into an ICU, I'm sad to say, there's already a 10% likelihood that that person is going to die there. But if they are to survive, it's going to be because more robust treatments are available at that level, and there are likely better patient to nurse ratios. 3-to-1 is a great ratio when it comes to an ICU. 2-to-1, 1-to-1. It all depends on what that particular person's illness and trajectory of illness may be when they enter that unit. Ultimately, that 10% number comes back in a different way when you look at something like CPR. We have, despite popular media, I think an unrealistic understanding of just how effective CPR can be. It has proven, dramatically so, Damar Hamlin, the Buffalo Bills, it was demonstrated to us absolutely on national television that timely and effective CPR saves the lives of healthy people who suddenly find themselves unable to breathe or to have their heartbeat on their own. Others who come in to a situation where they have already become medically vulnerable and CPR is indicated are not going to see the same kind of results. I wish it weren't the case, but I think it's important for us to understand that the kind of CPR that is effective, someone as robust, as muscular, as durable as Damar Hamlin could go ahead and come out of the hospital days later because his conditioning was such that his sternum didn't crack during CPR. At least I don't think it did. Otherwise, he would have stayed a bit longer. I'll bet his muscles and his sternum and rib cage were sore as hell, but he came out able to leave the hospital far sooner than others who might otherwise have suffered physical injury with CPR done right. I don't say this to say don't perform CPR. I say this to say manage your expectations depending on the situation and the original physical condition of the person who may find themselves in need. And please don't think that it is magic. It can help. I pray it helps, but I also understand if your 98-year-old great-grandmother might say, please put a do not resuscitate order or a DNR in my chart because my sternum will shatter if you try to do something like that. She may also go ahead and say, I don't want to be intubated either, a DNI order, where ultimately you need both a DNR and a DNI to avoid those chest compressions and artificial ventilation, no breathing tubes. Now, you might hit a situation where you say, this person is too fragile for CPR, but let's use cardiac drugs and let's go ahead and intubate. And then you find yourself in a situation in the ICU where, depending on how long they were down, their brain function may not recover. And then you're faced with a host of very terrible decisions. Irreversible illness is on this list for that reason. Or you may come into the hospital seeking comfort care for something unrelated to your terminal illness. A terminal illness is an illness for which there is no chance of recovery, and your likely prognosis, not a given, but your likely prognosis is 6 months or less to live. That's the criteria, by the way, under which most palliative care efforts that involve hospice are utilized. It is a medical requirement for you to be facing a diagnosed terminal condition for which the prognosis is 6 months or less. With comfort care, you could end up being recertified for multiple cycles of hospice. As a former hospice chaplain myself, I worked with patients who were on service where I served for a year and a half or longer, because they were no longer dealing with the after effects of aggressive care, and they were being taken care of through comfort measures for anxiety, for discomfort, to go ahead and alleviate secretions as swallow reflexes might become less robust, and simply being given tender, loving care to avoid skin breakdown and to make sure that nutrition and hydration aren't just given, but given with dignity and care and love. These people knew that they were loved. And ultimately, their quality of life and their quantity of life was extended. There are also cases in which people who enter hospice receive that very same tender, loving care and receive every loving gesture possible by family as well as professionals, and they don't last a week. That was the case of my own mother almost 3 years ago. The difference is in how you utilize comfort care, palliative care under certain windows, such as the window of hospice or the window of a palliative care team in a hospital setting, where ultimately you may need more care in order to counteract the effects of, let's say, a chemotherapy or a radiation for a cancer patient. Heroic measures versus A&D, allowing natural death. Those are really where I think the poles are when it comes to this whole enterprise and understanding the terminology. Do everything possible versus we've done everything possible. We are recognizing and accepting the mortality of the loved one and following their stated or written wishes. We want them to strictly receive comfort care until they die a natural, dignified death. I think whatever the choices are, obviously are situationally based, family system based, person-centered based, but you need to know the terminology as well as people's wishes in order to avoid miscommunication with the professional staff that is going to help you, whatever the stage of care is that's being provided. So reviewing the goals and priorities of care, understanding that a change in health status, an advancing illness, where the care is offered, are ultimately going to go ahead and have your treatment preferences evolve. For example, having a conversation with loved ones about, I want to have the best care possible until the day that I die. What does that mean? Does that mean do everything, heroic measures? Does that mean allow natural death? Does that mean someplace in between within that cornucopia of terminology that we had talked about a couple of slides ago? What does it mean when you say, I want to live meaningfully? Does it mean that you want to live in your home? Does it mean that you want someone else to care for you in that home? Does it mean that you want to move in with a loved one, or that you want to move into communal living, such as a long-term care facility? And wherever that setting is, what type of independence and what type of personal boundaries do you expect to be honored and maintained? And when you do die with dignity, whether it's at home, I put the question mark because the question mark represents outside of the home setting, such as long-term care or the home of another loved one, who do you want to see? What do you want to make sure has been said or written? If it's possible to answer those questions and prepare for them now, I think you're going to find that as powerful as grief is, it is grief coupled with closure, not just grief and unresolved issues. That's not to say that every single conversation describing your goals of care and who you want to see and what it means to live meaningfully is going to be fulfilled, but you are championing autonomy and dignity when you have those conversations. And that includes who makes decisions, if not you? Who gets the information about your care besides you? How do we talk about information with you? Depending on your cultural background, you may not want to know what the time frame or the trajectory of your terminal illness may be, but you'd rather that your eldest child know, or that a sibling know, or that a spouse know. Or you may want to say, I want every piece of information about what's happening inside of my body because that is my comfort place. My love language is the language of information. I need to know that I am being loved and treated with dignity by given everything that I could possibly want to know about the trajectory of my illness. It all depends. Determine your specific priorities. And again, we've talked about these, but it's worth repeating. Your values, your preferences, what are the clinical circumstances? What can the physician, the interdisciplinary team members, anyone involved in your care, whether it's aggressive, comfort, and all points in between, what can they do to help you come to the right decision for you? And how can that decision, with their help, if needed, be communicated with your loved ones and your community? How do we go ahead and restate in each age in which we live our life goals, our healthcare goals? Example, do I want to spend down my life savings with aggressive care measures while living with what eventually is going to be late-stage Alzheimer's disease? Or do I want to employ palliative care measures? They won't end up lengthening my days, but it's important to me that something of my savings be preserved in order to send children or grandchildren or great-grandchildren to college, or to help them in a future enterprise. Look, you might want to just take it all with you. And if you do, that's your call. You may want to go ahead and preserve as much as possible for the next generation, and that's your call. The answer is going to lie someplace in between, because your body isn't going to automatically stop at your call, unless you happen to live in a state in which the specific circumstances permit you to engage in medical assistance in dying. So it's going to be a compromise, but knowing what those goals are, whether they are achievable or not, can sometimes stabilize a family system that is in shock. Keep that in mind, regardless of whether the goal is achievable in full. Communication, communication, communication. Now, we will talk a lot more about this in later sessions, but we need to make sure that your advanced directives, if at all possible, and anything else you care to share about decisions you want made on your behalf, if you can't verbalize them or communicate non-verbally about them, are based on your ability to create, have signed and witnessed or notarized documents when you possess legal capacity and competency. Quick definition: to occupy a particular status or relationship with one another, to engage in a particular undertaking or transaction. I know that sounds really fun, right? But those are really important statements. If you can say who you are, where you are, what you are doing, what is going on around you beyond the place that you currently inhabit, you are demonstrating levels of alertness and orientation that will make it likely for you to be considered a person possessing capacity, possessing competency to engage in a particular undertaking or transaction, the undertaking in this case being the completion of an advance directive, the transaction perhaps being signing over or assigning someone as your medical and or durable power of attorney when you reach the point, should you ever reach the point, where you can't make reasonable decisions for yourself. And I hope to God that happens before you're in a hospital. So keep that in mind as well. Ultimately, would somebody look at you and say, this person doesn't need psychiatric evaluation? Odds are pretty good then that you have the capacity and or competency to go ahead and to have your wishes enshrined legally. And that's important because if suddenly you could not go ahead and share anything else with us, we would rely on those written advance directives first and foremost. If you could share with us and no written advance directives were able to be created, yes, you might have dementia, but yes, you may also be able to go ahead and to tell us what your preferences would be in various life-altering circumstances. But maybe you can't. Maybe you're past that point as well. Well, hopefully you've had conversations in the past with friends, with family, with community, and demonstrated through your own life's philosophy and activities the general values and beliefs that others should abide by when making decisions about aggressive versus comfort care for you and the situation that you find yourself in. Ultimately, if we can't do any of that, best interest determinations are what we're going to need to rely upon. And that's usually going to need the assistance of an outside party. Remember, hospital ethics committees, or as we have here at the Hope and Healing Center through HHCI CARES, the Community Healthcare Ethics Consultation Service, or CHECS. These are advisory only. Ultimately, a best interest determination might use some of the deliberations of a hospital or a community ethics panel, but you're going to probably need to go before a judge to figure out who is to be appointed to make decisions on this person's behalf if you haven't already taken care of those parts of the advanced directives umbrella. Just to be sure that everyone is clear about what I'm describing. The tools that I'm talking about are primarily the medical power of attorney, the directive to physicians, a living will, if you will. This is different, by the way, than an advance directive. A declaration for mental health treatment. I'm going to stop there for a moment before I go to the fourth category on this list, the out-of-hospital do not resuscitate order. The reason why is because ultimately those first three documents can go ahead and be signed by you and witnessed by adult non-relatives and in most cases, non-employees of the healthcare institution in which you may find yourself. So it's not too late if you enter the hospital and the situation is such that you still have the capacity, the competency to say, boy, this was a wake-up call. I really need to get this stuff done. While you're in that hospital, but ideally, maybe with your primary care physician before you ever enter a hospital, God forbid. If you've made a decision that you don't want emergency response personnel outside of the hospital, hence the name, to perform CPR on you, in the end, you can execute with a physician's signature an out-of-hospital do not resuscitate order. If you do so because you have decided perhaps you're too frail, you have a terminal illness that has been diagnosed, and the prognosis is whatever the prognosis is that has led you to the decision to refrain from heroic measures such as compressions and breathing for you, do yourself a favor and make multiple copies. Make sure that ultimately the original is in a place where you know and can easily access, or that the people who are working on your behalf know where it is and can easily access. If that means going ahead and putting it in a sleeve and tacking it above your bed, do it. If it means tacking it on the inside of the front door of your house, do it. Whatever it takes in case somebody panics, good intentions, and calls for first responders. Without it, they will have to initiate aggressive measures, and autonomy and dignity will be compromised because they have no choice. You don't want to go there if you don't have to. So if you find yourself diagnosed with a serious or ultimately a life-limiting illness beyond the natural life-limiting part of this world that we all share, I think it's important for you not just to ask the doctor these questions in order to have your own sense of understanding what to expect moving forward, but so that loved ones and people making decisions on your behalf, whether they're the same loved ones or other people you appoint, understand what you understand about the trajectory of the illness, about what you hope the treatment might do, but also how the treatment, if any, will make you feel, and the pros and cons and alternatives of that treatment. I think it's really important to understand, and I'm not being grim here, what is it like to die of the disease that I have? And how can medicine ease my symptoms? You want people not to mistake an end-of-life symptom for which you may have made a decision to go very gently as something that requires an emergency response, thereby disrupting your plans as well as your autonomy and dignity. Will you, the person I'm consulting with, still be my doctor if I opt for some form of palliative or comfort care, or if I enroll in hospice? When do patients with my disease, if they do enroll in hospice, when do they benefit most by doing so? Sometimes we find ourselves in a situation where we have gone ahead and listened to physicians who are extremely aggressive on our behalf. And unfortunately, they have not been able to arrest the disease in question. I'm thinking oncologists in particular, who, to be fair to oncologists, are trained to never give up. But in the end, is it important to continue aggressive treatment for its own sake? Most people would say no. So even with the oncologist who is there to be as aggressive as possible on your behalf, I think it's important to go ahead and to say, hang on, when would I benefit most by switching from aggressive care to comfort care, and most likely in that case, under the umbrella of hospice services? Have the conversation, because it is your body, your decision. And while you're doing that, ask yourself, what activities or capacities make my life worth living? What are my greatest fears and regrets? And given that my time may now be shorter than I expected it to how do I want to spend it? Atul Gawande wrote in his book, Being Mortal, a story about a patient who, well, his wants were simple. He wanted to be able to continue to eat chocolate ice cream whenever he wanted, and to enjoy football games, live or recorded. So his doctor managed his treatment with said goals in mind. This is why you have these conversations with loved ones well before you face a situation, or if you're in a situation, it worsens beyond a point where you can have a meaningful discussion. And when all is said and done, because we all will shed this mortal coil, it's part of the hopes and rites of passage, leaving a good emotional legacy, enjoying the time you have left, whatever adventure means to you, modeling for others as well as giving yourself the experience of embarking upon it, and leaving your loved ones in whatever good shape means to your family, physically, emotionally, spiritually, financially, you name it, whatever it is, have those discussions. It is not taboo to discuss any of these when you're facing life-limiting situations. And since we will all eventually face them, by definition, it's always okay to have these conversations. That may involve some reframing, especially amongst the generations that may never discuss feelings, bank accounts, and other such things that have been, for whatever reason, drilled into them as being purely private. We're not seeking to invade anyone's privacy in having conversations like these. What we're seeking to do is to uplift and support when they can't speak for themselves. So in the end, you and your family should, well, know thyself, or know thyselves if you prefer. Think about your plans before they're needed. Formalize them with directives. And please, please, please continue to talk with your family members. And if your relationship with family is complicated, welcome to the human race. The family members I'm describing aren't just people who might be good organ donors for you. I'm talking about the family that you have found along life's journey, not just the family you're born with. If you are blessed to have both available for support, outstanding. If you are left with limited options, make sure they understand so that they in turn can be your voice when no one else can. So we have other options for you to consider beyond what I've said today. I hope that they are reinforcements and not refutations of anything that I've shared. That's the plan, at least. I think they should be supportive since I put them in. Ultimately, I'd like you to consider reading Being Mortal. I'd like you to consider The Art of Dying Well, The Denial of Aging. I'd like you to look at practicalbioethics.org and look at the Caring Conversation Guide if you don't know where to start. mydirectives.com. Great resource if you're not sure where to start when it comes to advanced directives. If you already have a sense as to how to start with those, skipping down to the state of Texas Health and Human Services, they have boilerplate advanced directive forms right there for you to use. And if you go to texaslawhelp.org, another way of potentially getting some assistance would be to go ahead and to put in place a supported decision-making agreement in which you maintain autonomy, but outside of someone taking over your life legally and medically, rather than doing that, you have someone who is designated as being your voice alongside you. Now, we all do this to a certain extent informally, but I'm finding more and more as we live longer and longer, and thank goodness maintain our faculties for longer and longer, that supported decision-making agreements are actually just as important in the long run to have in place, as well as people who you have legally assigned as your power of attorney for medical decision making for financial matters, your durable POA, in other words. And respecting choices, which I skipped over to get to those last 2 points. I think it's important for you to see, even though we're at a different stage of the pandemic period, that because it is an example we can all relate to directly or indirectly of life limiting situations that we have faced globally, of how to have a conversation about the choices you make that emphasize quality of life versus quantity of life, when quantity of life is no longer a realistic possibility. We are going to encourage you to continue having conversations like this if you've started them. Hopefully start them if you haven't yet done so. And either way, if you have questions or if you need another voice in the room or outside the room whispering in information you may find useful, Peggy and I are available for individual and family consultations. And our contact information, of course, is here on the slide. A reminder, everybody who registered is going to get a copy of the recording. Some of you have been listening to this recording from beginning to end, and that's wonderful that you're learning at your own pace. For those who have been listening live, we truly appreciate you taking the time to do so. You're going to get the recording if you want to go back and review anything. And you're also going to end up with a copy of the slide deck. And that's going to be the case for all 4 of these sessions. So let me go ahead and stop sharing my screen. We are right at time, actually a little over time. But I did want to go ahead and just double check and see. I don't see any questions in our chat box. So ultimately, I'm going to invite you, for the sake of respecting the time you've blocked out, to contact us. If you didn't go ahead and write down that information, again, the slide deck is coming. But the easiest way to contact us in the short term, if you have a timely need and prefer not to wait, is to simply go to our website, HHCI.org. That stands for the Hope and Healing Center and Institute, HHCI.org. You can click on the tab for HHCI CARES, and you can certainly reach out to us that way as well. Or you can always contact our main line or our general information email, and you'll get to us too. Thank you, everybody, for your time. Have a wonderful week. I find that this is a great way to start my Mondays, so I hope you feel the same. And we will look forward to seeing you. If you haven't yet signed up for the remaining sessions, you can just go to our website, hhci.org/events. And then you can go ahead and click through there. It'll take you to Eventbrite. You'll be able to register. And again, you're going to get a recording and the slide deck for each one of these. Have a wonderful remainder of the day, everyone. Be well.